Hey guys, I'm going to do my video presentation over my analysis paper. Last one we'll ever do, hopefully. Um, but it was over bias, and I think in our profession that's something that's brought up a lot as far as being very opinionated, and how that could affect the way you deal with your patients. And I chose to write mine over biased when dealing with, like let's say like frequent flyers, or not even that, but patients that call for a certain reason that may not present with certain symptoms that we think they should have, or no symptoms at all. And I feel sometimes, we get complacent and let bias take over and not complete a proper assessment, or not complete a proper history, because we let our biased opinion dictate the type of treatment that person gets. So again, I chose to write mine over a biased opinion on like patient assessments. So like I said, we're just getting started as far as our EMS career, as far as paramedics go. Even as basics, you didn't really have to deal with the types of treatments and things that we have to do with, as far as paramedics go. And I think the longer you are in the EMS, and the longer you're in charge of a call, I think it's easier to get complacent at times. Like I said, I've been an EMT for about 13 years, but even then, I never worked for an agency. I've been on the fire department for the last 6, so that's about all the medical side of it that I had to deal with. And even then, 5 years of it was just BLS. So we just first responded with the agency there in town. But as I've been on Owasso, I've realized the importance of the proper paramedic to patient contact and the treatment that they should have. And the longer you're with it, like I said, you'll get into some of those situations where you have those frequent flyers, or people that you're on a first name basis. As an example, we had here in town in Owasso, we have particular patients that will call. We're on a first name basis with them. We know them, they know us. But I make it my point every time to treat it like it was real. Although they might not have something going on every single time, it just takes that one time that they could. And because of our complacency and our bias against them, we skip very crucial steps in that part of the patient contact. So, like I said, we all know them. I pulled up the other night, and they had their bags packed. They're outside. They have their medication list all drawn up. I mean, they know the drill. But even on those patients, you have to leave bias out. So just kind of briefly touching over some of the stuff in my paperwork here. Obviously, I'm sure we all looked up the definition of bias in order to write the paper. And that's something we hear a lot, but I didn't fully understood it till, read a couple definitions. And they varied a little bit. But for the most part, what I got out of it is it's really just, it's a prejudiced opinion. I mean, simple as it is. It's like a tendency, a belief, inclination, or an opinion that we have about a certain group, person, or thing. So, we run those frequent flyers, we're biased that, hey, they're just calling because they're, it's that time again. But we got to leave that out of our patient assessment. Let's see. Because like I said, all it takes is that one time that something could be seriously going wrong. They could completely be, asymptomatic, but we skip those parts of that step. We're not able to find it. They go into arrest, or, something major is going on that the doctor finds that we didn't report to them because we didn't take the time to properly assess that patient and treat that patient. So, like I said, I think we need to get in our mind, even starting now, throughout our career, leave bias out. We got called for a reason. We're to treat our patients with the utmost respect, and we're there to care for them, care for their needs, whatever they're complaining about. No matter how many times we respond there, it's their call. We got to put those biased opinions aside they called us for a reason. You know, to them it's serious, so we should take it serious. And another thing I think about, I used to work in the town where all my family lived there in Sapulpa, and I wouldn't want, the EMS agency showing up and having a biased opinion about, one of my relatives. There for a while, my grandfather was going through cancer, and they were getting called quite a bit, not like every few days, but, at least once a week. And I wanted to make sure that when they showed up, they were doing the proper assessment, getting a proper history, treating his symptoms, looking into things that he was complaining about, because I knew he was sick, so I wanted them to do that. And I think you should think of it like that when you run on a call. They might not be presenting a certain way that you think they should, but they're sick. To them, they're sick, so you need to treat them. I did some reading on like the gym's website, and I found some pretty good reads, and all of them were just stories of paramedics being complacent. They showing up on calls. Patient appeared fine initially. They're skipping vital parts of their assessments. And that's something that we need to leave out of every assessment. There's a reason we've been drilled that, from P1, patient assessment and the history are literally, that's what makes the call. You can't treat anything that you don't find, and you don't know what to look for if you don't get a history. So, 18 months of school, starting from day one, that's what we were told. So, just kind of briefly hit on some of the scenarios that I read on gyms where a bias had gotten some paramedics in some trouble. It was back in 1990. It was a case of Wright in the city of Los Angeles. It happened where patients are characterized according to their initial impressions or initial presentations. So rather than the thorough patient assessment we're taught, in the call at the center of the Wright case, paramedics found an African American laying in the street with an altered level of consciousness. Instead of doing a complete secondary survey, they assumed he was intoxicated and provided very little in the way of care for him. Well, he wasn't intoxicated. He was suffering a sickle cell crisis, and they did little to help him, and he died on scene. So, again, not doing a proper assessment, the dude actually had something going on, and they didn't catch it because they assumed he was intoxicated. Probably wasn't dressed. Maybe was dressed like he was homeless or not well taken care of, or maybe lived on the street. So they let that biased opinion just assume that, he's intoxicated, so we'll just load him up, figure out what's going on. But in fact, he had a real emergency going on. So I think that's something. And then, as time goes on, I think we let our, we see so many patients, we get in our head what a patient should be presenting like. And there was another story of where paramedics are getting overconfident. The patient will tell them something, and then they look for reasons to, other reasons to to confirm what the patient's telling them. So like, oh yeah, do you have these symptoms too? And then they're just looking for that reassurance that, hey, this is what's going on, when, they're skipping over steps. They're not doing a proper assessment. So, let's see here. That was called the diagnosis momentum. It states we let our biased opinion attach a label to a patient, and that label tends to stick. So we get something in our head, and it's stuck in our head. We look for ways to confirm our opinion instead of completing a proper history, a complete exam, and a complete history, and we miss important findings. So, it was another one that it was talking about that got some paramedics in trouble. And then let's see what else we have here. So obviously that leads to poor decision making, errors in our biased opinions. Although much of our initial EMS training is focused on skills and learning didactic information in various illnesses and injuries, we got to rely on the critical thinking. You got to think of more. Like, you can't just take it at face value. Like I said, every patient presents differently. Every patient is going to have different complaints. Maybe one's, super emotional, one's able to deal with the pain a little bit better. But we got to get out of our head that patient with this complaint is going to have these signs and symptoms, or yada, yada, yada. You got to take the time to figure out what's going on, get a proper history, and don't get complacent. I mean, like I said, over time, I think that's something we need to always keep in our head. Think about how nervous and how much of a detailed history and assessment we do now, and stick with it. I think when we start getting more comfortable, we've seen more patients, we kind of get in our head, we know what we're doing. We just tip the iceberg of knowledge compared to like a physician. So, we walk in there all confident thinking we know what's going on, and then, what does the doctor do the first time he sees a patient? What's going on? What's your history? And he digs into it. He doesn't just take it for face value. They're going to do blood work. They're going to do an EKG. They're going to take vital signs. They're going to get their medications, and every single patient. That's really, I think we need to be like that. So I think that was one thing that I really got out of it was, taking the time to do what we're taught from day one: proper history, proper assessment, and a focused, detailed exam. We got to look for things. They're not just going to jump out at us. So, I think a lot of times, like I said, we let that biased opinion get in the way. We think in our head, this patient is just calling because they call, or this patient is saying this, but they're not showing the classic signs and symptoms. They just want to ride to the hospital, or, they're lonely or something. But that's when we start getting in trouble. So I think we got to focus on more of the critical thinking and asking the right questions. I mean, we're basically got to be like a little investigator when it comes to their illness. So, like I said, I think it was a good topic for P4, especially going out thinking we know what we're doing. Just that little bit of confidence we have with the knowledge that we do have. I don't think that needs to lead into us being lazy. We still have a job to do. We still got to be professional, and we still got to, treat every call like it's that patient's, most serious call ever. So that's what I got out of it, and that biased opinion about skipping steps. So like I said, I know I was kind of jumping back and forth, just trying to get it all in there. But if you have any questions as far as, or you disagree or anything, let me know. Like I said, I'd be glad to talk about it. So good luck to you guys, and hope it was informative. Thanks.